taken out after the party last night. This light topic, and just want to congratulate the organizer on a fantastic meeting. So this is what we're going to discuss. Just the optimal technique for neonatal MR. That obviously we're focusing on hypoxic ischemic encephalopathy and then all the differentials. And we'll look at clinical and imaging findings that will help us distinguish metabolic from hypoxic ischemic brain injury. And I'll illustrate some recognizable neonatal neurometabolic disorders. This group, because they present with acute encephalopathy and are usually overwhelming and dramatic in presentation, they are also known in the neurology textbooks as the devastating neurometabolic disorders of the newborn. And this has been covered in the meeting, even though we didn't have a specific talk on neonatal encephalopathy, hypoxic ischemic encephalopathy. But I'll just call attention that it is optional to use dedicated B values for premature and newborns due to the water content of the brain being different. And it was also mentioned on the first day, I believe as Dr. Whitehead, MR spectroscopy. There are some differences in the baseline for long versus short TE, and it's preferential to do both if you have a suspicion that it's something else other than HIE. For detection of lactate in HIE, I typically prefer just a long echo time spectroscopy. We should all remember that from a neonate to a post-neonatal brain, there is an evolution in the spectra. So choline will decrease as the brain matures and NAA will increase. So shouldn't be confused by looking at neonatal spectroscopy. And also, as I mentioned, the baseline, the number of metabolites will decrease. The baseline will be cleaner at a long echo time because the peak heights depend on the concentration of the metabolites, but also on their T2 relaxation time. So this is easier to look at, but if you're looking at the potential unknown metabolite that can indicate a metabolic disorder, you also have to do the short echo. I don't do intermediate time spectroscopy anymore, but we should remember that there is a J-coupling phenomenon and the doublet of lactate will be negative between 135 and 144 milliseconds. And you should also remember that lactate just indicates anaerobic glycolysis, so your brain is shifting energy production. There's some injury and some difficulty going on with hypoxia ischemia, but it's not by any means specific for mitochondrial disorder. So lactate does not equal an inherited mitochondrial disorder. If we talk about all these groups of disease, this is a slide inspired by Dr. Hausman. You have this group of rare disorders that seem to have nothing in common, but when you start looking at them, collectively, they form a good number of diseases that are usually aminoacidopathies or organic acidopathies and acidurias. They present with acute, overwhelming encephalopathy that mimic more common neonatal disorders. Many of these are treatable, and I'll show you the categories. So rapid diagnosis, which includes neonatal screening that may take time, and sometimes neuroimaging as an adjunct to the clinical and laboratory investigation may help prevent irreversible injury. So there are many clinical findings, but I'll call attention to this morphic face of the child and characteristic odors. We all remember maple syrup urine disease, but there is odor of sweaty feet and urine and so many that I decided not to put a table here, but I'll suggest some reading that has these tables with all the different smells that a newborn can have. Laboratory tests, the one thing I would like to call attention is that any unexplained metabolic acidosis should be considered an inherited metabolic disorder until proven otherwise. But there are many types like hyperammonemia and metabolic acidosis with ketosis or not, with an anion gap or not, that can point to the specific metabolic abnormality. And then our area of MR imaging, due to selective vulnerability of parts of the brain, we can work our pattern recognition using DWI for cytotoxic intramyelin edema and acute parenchymal injury. And sometimes a mass spectroscopy may also be helpful. As I mentioned, I didn't see on the program a specific talk on the patterns of injury of hypoxic ischemic brain injury. So I just decided to add this one slice to remind us that the brain activity at the time of injury is crucial to understand the pattern you're going to see, because a premature brain due to the pre-oligodendrocytes that are immature, the white matter will be most vulnerable versus a term brain. Then the severity of hypotension and hypoxia here, the dominant factor is the hypotension. In moderate or profound, will affect mostly the gray matter structures if it's profound, since there is no time for shifting of metabolic activity and cerebral blood flow. The duration of the event will cause more selective or more widespread injury. And of course, the timing of MR imaging. This has been described, studies from Dr. Barkovich's group, maybe 15, 20 years ago. But in profound injury, you start with restricted diffusion and acute injury of gray matter structures. And then from secondary cytotoxicity and release of glutamate, you see that restricted diffusion migrating a few days later, usually 5, 6 days after the injury, to the white matter. So all of this is important to know if you're dealing with a classic pattern of hypoxic ischemic brain injury. And I'll just exemplify with the basal ganglia thalamus pattern on ADC maps. And then T1 and T2, just some swelling of the basal ganglia, particularly on T2. Classic location, posterior putamen, ventrolateral columni. And day 8 after injury, the astrogliosis and tissue necrosis will cause the posterior putamina and the ventrolateral columni to be T1 hyperintense, while there is near complete loss of that dash of myelination in the posterior limbotemporal capsule, which predicts very poor motor neurodevelopmental outcome. So just one of the classic patterns in this case, profound but brief injury related to this selective basal ganglia thalamus pattern, and also perilaryngeal. The other pattern of injury that was shown in this meeting, and we should remember, is neonatal hypoglycemia with this predilection for the posterior, so parietal and occipital cortex and white matter, plus secondarily the dorsal columni and the splenium. This may be isolated. It may be in conjunction with hypoxic ischemic brain injury or with a neurometabolic disorder. So it could superimpose all of these entities. So when do we suspect that there's a neonatal metabolic disorder and it's not just HIE? An acute encephalopathic newborn, usually at term, there's no correlation with prematurity, typically normal at birth, so you'll see normal Apgars. A few days later, metabolic decompensation leads to refusal to feed and vomiting, hypoglycemia, acidosis, acute liver failure, lethargy, coma, seizures, and here's the role of hypoglycemia, sometimes hyperammonemia as well, and changes in tonus. In fact, hypertonia, spasticity, hypotonia, they may all, or even alternating, may suggest a particular disorder. These are typically disorders of intoxication, so you have too many metabolites. Remember I mentioned they can be organic or amino acidopathies, disorders of energy production or biosynthesis of complex molecules. So the test may be to look for this substance in the urine or in the blood, or sometimes very long-chain fatty acids in peroxisomal disorders. The clinical manifestations are quite variable because they depend either on the residual enzyme activity, accumulation of the intermediates, or energy and substrate deficiency. And they may even present prenatally and cause malformations. So here are some of these disorders. And mitochondrial disorders may present neonatally as well, and urea cycle disorders as well. So let's look at a few examples. This is a 12-day-old girl born normally, vomiting and poor feeding later, alternating muscle tonus, which suggests the disorder. We notice the entire white matter on tissue-weighted images is swollen, but on diffusion-weighted images, only the myelinating white matter of the corpus spinal tracts, thalami, and long tracts of the brainstem and then the cerebellum are restricted. I'm showing here just a DWI. So this is a classic example of maple syrup urine disease and accumulation of leucine, and may also show spectroscopy a peak at 0.9 due to branched-chain amino acids. This pattern has been called myelination map of maple syrup urine disease edema, and it's very unique because it has restricted diffusion in the myelinated white matter and vasogenic edema in the remainder of it. Quite recognizable for us. Here's the peak of branched-chain amino acids at 0.9. Second case here, a 2-week-old girl presenting with seizures. It has dysmorphic facial features, so prenatal onset. And we notice the contrast in the image is not the best, but there is some